Um, Good afternoon, ladies and gentlemen. For those of you who are in the UK or in Europe, good morning for um, those of you who are in the Americas, and good evening if you happen to be in Asia. We are going to start our webinar on PicoWay, concentrating predominantly on the pigmentation and remodeling. For your information, this webinar is all going to be recorded, so you can access it afterwards. The duration of the webinar is 30 minutes, and then afterwards we will have 15 minutes of questions and answers. You can submit your question during or at the end of the webinar when we will have the Q&A session, and I will then answer all your questions. So we will start now. So a little introduction about myself. For those of you who don't know me, my name is Firas, and I am based in the United Kingdom, in London. I work with lasers predominantly. I am a consultant dermatologist, mostly in the private sector, and work with many of the Syneon Candela devices. And I will be talking to you about the PicoWay and sharing my experience too. So we'll start with an introduction before we delve into the PicoWay. We'll just give you a bit of background history of the Q-switch lasers. Q-switch lasers were around since the 90s, and they came after the photothermal theory and allowed us to treat pigmentation and tattooing particles selectively with little surrounding damage, given the fact that they had a very short pulse duration in the nanosecond domain. Most of the Q-switch lasers in the market have a pulse duration somewhere between 5 to 50 nanoseconds. Now bear in mind that the shorter the pulse duration, the more photoacoustic effect you would have compared to a photothermal effect when the pulse duration is longer. So the Q-switch lasers will have a combination of a photoacoustic or a photomechanical effect as well as a photothermal effect. We are, however, now pretty much into the picosecond lasers era. They have become available in dermatology since 2012. And the key thing about the picosecond lasers is that the fact that they produce very short pulses in the picosecond domain. To just put that into perspective, the 1 picosecond is 1,000 nanoseconds. So you can then see that the shorter the nanosecond pulse duration, the closer you are to the pico. But also the longer the picosecond duration, the closer it is to the nanosecond. And then the advantage of having a picosecond laser is that you rely more on a photoacoustic or a photomechanical effect compared to the photothermal effect, because the pulse duration is very short, so there will be more of a shattering effect and therefore less heat produced, which also means less pain, but also a higher safety profile. And this really has transformed the way we remove tattoos. But most importantly, the picosecond lasers are not restricted just to tattoo removal, and they have a wide range of uses outside of tattoos, namely pigmentation and rejuvenation, particularly when it's used in the fractional mode. So what do we know in terms of the evidence? The evidence has shown us that when we are using shorter pulse durations, we are safer because we have more photoacoustic effect compared to thermal effect, as I just explained, and therefore there is less bulk heating and it's less painful. And because of the shorter pulse duration, we are having better fragmentation of the particles, and therefore to have an effective picosecond laser, we would want one that will have a high peak power with the lowest energy. So I will spend a couple of minutes explaining this slide, because I think this slide is the key important slide in understanding why the picosecond lasers are better than the nanosecond lasers when it comes to tattoo removal. And I'm just spending a few slides on tattoo removal, and then we'll move on to the pigmentation. To fragment and break down a particle, and in this case we're talking about an ink particle, the short pulse durations in the picosecond domain will generate stress wave tensile force. And when the stress wave tensile force exceeds the stress confinement time of the particle, that leads to fragmentation of the particle. So you would need to have a stress tensile force that is higher than the stress confinement time. And the stress tensile force here is linearly related to the fluence and inversely related to the square of the pulse duration, which means that by simply shortening the pulse duration, you will have a much higher stress wave tensile force by just having a fixed pulse duration and increasing fluence. Because this was the principle that we had when we were using nanoseconds. As the pulse duration in the nanosecond laser machine is fixed, each time the tattoo is being treated, and then the particles are being fragmented into smaller particles, therefore their stress confinement time will increase, and to match that and exceed the stress tensile force, the only thing we could do is increase the fluence, hence we increase the fluence with each subsequent treatment. But for the same fluence, if you shorten the pulse duration, you would have a much higher stress tensile force that will then exceed stress confinement time, and that leads to particle fragmentation. And this is why with the short picosecond laser, with the short pulse durations of the picosecond lasers, we have much more of a photoacoustic or photomechanical effect, therefore much more shattering effect with less photothermal effect, which again means higher efficacy as well as safety and less pain and discomfort to the patient. So why is the PicoWay a unique picosecond laser? Well, it's unique because to start with, we have three wavelengths, the 532 nanometer, the 1064, and then this unique wavelength, which is the 785 nanometer. This is a titanium sapphire generated wavelength that is particularly good to treat green and blue tattoos, but of course can also now, if you have that wavelength, treat pigmentation too. It has the highest peak power, and that means that you are able to have a large spot size, and even with a large spot size, you can still generate enough fluence with a very short pulse duration. And to be able to generate very short pulse duration very much into the picosecond domain, you would need a machine that has high peak power. Now, the last table, the last column with the shortest pulses is particularly important, and I want you to pay particular attention to the pulse duration here. And what you will notice is that all three pulse durations are below 500 picoseconds. And that is important because remember, 1000 picoseconds will equal 1 nanosecond. So if you have a picosecond laser that has a pulse duration of 900 picoseconds, that is still, of course, a picosecond laser, but it's very close to the nanosecond, and therefore will have much more photothermal effects compared to a picosecond laser that will have a shorter pulse duration. So the pulse durations that are shorter than 500 picoseconds very much rely on much more photoacoustic effects with less photothermal effects. So in summary, the key thing about the PicoWay is that in addition to having large spots sizes, three different wavelengths, is that you have unique short pulse durations below 500 picoseconds, which very much lie in the heart of the picosecond domain and rely on more on photoacoustic effects compared to photothermal. And the 532 nanometer is the one that we would use for red pigment, for red tattoos, and you can see here when this was trialed against a control, 100% of all the particles were fragmented into very small particles. And this clinically leads to improvements of the tattoo and the tattoo being less visible. And this is when it was compared to the Alex Trivantage, which is a Candela tube switch laser with a long pulse duration of 50 nanoseconds, and you can see the difference in terms of the shattering force to very small particles with the PicoWay. If we look at the black ink, and black ink is what we will treat that in the 1064 nanometer, again you will see the majority of the particles have been shattered to very small particles. And this shattering of very small particles is predominantly owed to the very short pulse duration of the picosecond laser. So the 532 is what we will use for red tattoos. The 1064 is what we will use for black tattoos. And this 785 nanometer, which is a titanium sapphire generated wavelength, is particularly unique and good for green and blue inks, which has a much higher absorption in that wavelength compared to the 1064, and therefore you don't need higher fluences, and it's much more effective in treating green and blue tattoos with less complications. And this was the paper published in Lasers in Surgery and Medicine that led to the FDA approval, and it is a nice paper describing the efficacy of this unique wavelength. I hope the video is showing, and here what I have is a short video. It seems to be a problem getting the video, but it was a short video on the use of the PicoWay laser in tattoos. But here you can see some nice clearance of tattoos, and in this case after a single treatment, and here because of the color of being the 1064 nanometer will be used. And in this particular case from one of my colleagues, Dr. Dato in Geneva, you can see that there was limited improvement after several sessions with the Q-switch. However, once this tattoo was then treated with picosecond, there was much better clearance. So this is the slide that summarizes the wavelengths that we will use for tattoos. The 532 nanometer predominantly for red, but if you happen to have orange, yellow, or purple colors, that's the wavelength to use. And the 785, as I say, is the green and the blue colors. And for the black colors, we would use a 1064. In terms of the settings, that of course depends on different variables such as the ink density, skin type, and the clinical endpoint, which is the frosting, particularly in the first few treatment sessions. It is best to start with a larger spot size and require less fluences, and then move on to incremental increase of the fluences based on the response. I personally prefer an 8 to 12 weeks interval, particularly if there is a lot of density of the ink. That is to allow time for the macrophages to clear as much of the pigments as possible. In general, for the black tattoos, you would need around 1 joule to start getting clearance. So I would suggest you start with a 6 millimeter spot. So that was covering a bit on the tattoos. However, the main reason we're having this webinar is to concentrate on some of the other uses of the PicoWay, which is the pigmentation and tissue remodeling. These are a couple of my papers that I have published in this field, and picosecond lasers. The first on the use of picosecond lasers beyond tattoos, and the other one on the applications in pigment reduction and tissue remodeling. So when it comes to non-tattoos, we have two handpieces: the Zoom handpiece, which gives 100% coverage. So this is the non-fractional handpiece. We refer to that as the Zoom handpiece, which we obviously use for tattoos, but we can also use for pigmentation and for what we call picotoning, which is the same principle as laser toning. Then there is the fractional handpiece, which is the unique handpiece that we call the Resolve handpiece, which we can also use in pigmentation, as I will show you, but particularly good for rejuvenation and for the treatment of mild to moderate acne scarring. So the Resolve handpiece comes into the two wavelengths, which is the 532 nanometer and the 1064, and it's a fractional non-ablative photoacoustic way of generating tissue remodeling. And what it has this unique feature of a holographic fractional technology, where there is a beam splitter at the lens that splits the beam of light into very high-powered spikes of energy with no background energy. But if you look at the total amount of energy, that is still low, but essentially you're splitting using that holographic fractional technology to split the beam of light into spikes of energy. And what they do is something that has been well known for over the last few years, and those of you who have been attending laser conferences or reading the laser journals will be familiar with this term that we refer to as the LIOBs, light-induced optical breakdown. And these are created through plasma formation, and we know now that melanin is the absorber, is the absorbing chromophore that absorbs these wavelengths and therefore ejects an electron and generates these structures that we refer to as LIOBs, light-induced optical breakdown, predominantly occurring in the epidermis, but have also been shown in the dermis. And what these LIOBs do, then they promote, they trigger a wound healing process in a non-ablative way, and that wound healing process has shown to lead to better collagen and elastin formation. So it is a non-ablative, controlled way of injuring the skin, predominantly in the epidermis. That's where most of the LIOBs were observed, in the epidermis. The reason for that is because melanin is the primary target, and melanin is mostly concentrated in the epidermis. And then that LIOB, the light-induced optical breakdown vacuole, generates a cascade of wound healing process and an inflammatory response that leads to tissue remodeling, but also, interestingly, to microscopic epidermal necrotic debris, and that also helps with clearance of pigmentation. So one could view the Resolve handpiece as a fractional, non-ablative, but it's non-thermal, and that's why it's painless and safe in darker skin types and does not require anesthesia. So one of the key questions I often get asked is, what is the difference between this mode of fractional treatment and the other fractional non-ablative lasers? And the key difference will be that no anesthesia is required and it's painless, and that is because it's non-thermal. It's purely due to the creation of LIOBs without the heat, and there was histology and numerous studies to support the improvements in the collagen and elastin afterwards. So, can we use the PicoWay outside of tattoos, beyond tattoos? Absolutely, as I mentioned and published already on this. And this can be used for skin rejuvenation or toning, or fine lines and wrinkles, for scarring, and of course for epidermal and dermal pigmentation. So I think it's helpful to just have some kind of an algorithm for the choice of parameters, because that tends to often be one of the key things on which parameters to choose, and I will give you my set of parameters. But I think first of all it's important to just answer the question is, what is your target? Where is your target? Are you dealing with epidermal pigmentation, such as with lentigos, or are you dealing with dermal pigmentation, such as nevus aphota or post-inflammatory hyperpigmentation, or is the aim rejuvenation or treatment of fine lines or acne scarring? I think that's the first thing. And then, based on that, you will choose the appropriate wavelength. So for epidermal pigmentation, the 532 nanometer is your wavelength of choice, and for dermal pigmentation, the 1064. The Resolve handpiece, which is the fractional non-ablative handpiece of the PicoWay, can be then used for rejuvenation or for acne scarring, or what I would describe as field pigmentation. And that is when you have a large area of pigmentation that you would like to treat. In addition to the Zoom handpiece, that's where I find it particularly useful as well. And then you will choose your spot size. So generally speaking, I prefer larger spot size to start with for tattoos and dermal pigmentation, and for picotoning in a similar way that we were used to do that with a nanosecond, which is with a large spot size, low fluence and high frequency. For epidermal lesions, generally speaking, a 3 or a 4 millimeter spot size, and then the fluence will be based on obviously the target chromophore, the concentration of the chromophore, the background skin type, and the clinical endpoints. You can use a larger spot size for larger lesions such as a cafe macula. The clinical endpoint, I think, is particularly important as well. And for most of the treatments for pigmentation or rejuvenation, you're looking at erythema, the uniform erythema in the treated area, and for the epidermal lesions, darkening. You can sometimes, when you're treating with a 1064 for dermal lesions, you can expect sometimes some mild petechia, but generally try and avoid a lot of the petechia, particularly in darker skin types. And then mild frosting is expected in some cases of epidermal pigmentation, but try not to get very much of frosting in darker skin types, as that can then subsequently lead to post-inflammatory hyperpigmentation. I think this is an important slide, and I will leave this on the screen for a few minutes. And I want to just warn you not to just copy and paste exact parameters, because that obviously depends, again, on the condition that you're treating, the skin type, the sensitivity, and also the clinical endpoint. But this is a rough guide of how I approach things when I'm using the PicoWay. So, for example, just going back to this, if I'm using it for melasma, the way I use it for melasma is I always start with the 1064 resolve handpiece, and these are the fluence estimates that I start with. Do a couple of passes, and my clinical endpoint is erythema, and then after that I do the pico toning with a large spots 1064 lower fluences, and then multiple passes, somewhere between 2 to 4, of course, judged by the clinical endpoint. For the lighter skin type patients with predominantly epidermal melasma, I also use 1 or 2 passes maximum of the 532 resolve. Again, you have to just be careful using that on very dark skin patients. In that case, I will just limit the use of 1064 resolve followed by the 1064 zoom. We are going to publish our results and experience with melasma using this combination technique, but this is particularly what I have found a very useful technique in terms of melasma. If we move on to epidermal pigmentation, so as I mentioned, the epidermal pigmentation would require the 532 nanometer wavelength, and for that I use the zoom handpiece with these kind of spot sizes, and I start basically with the lower fluence that would give me the clinical endpoints. But you can see there is a wide range of a starting fluence, and again, that depends on the concentration of the chromophore and the background skin type. For field treatment, so that is when you're not dealing just with a single epidermal lentigo, for example, but there is a whole field of cheek full of lentigos and some photo damage. In lighter skin types particularly, I like to combine that with the 532 resolve, and these are my settings. Obviously for dermal pigmentation, and that includes post-inflammatory hyperpigmentation, would be using the 1064, and again I like to use the resolve handpiece first, followed by the zoom handpiece, but in this case when I'm using the resolve, my fluences are higher than melasma. So in general for melasma I tend to use lower fluences. That goes also for the resolve handpiece, but for post-inflammatory hyperpigmentation, slightly higher fluences. For acne scarring and rejuvenation, you are purely there in the resolve fractional handpiece. So I like to start again with higher fluences for acne scarring, and then multiple passes, up to 4 passes. And for the lighter skin type patients, we'll use also the 532 with higher fluences than I would normally use for melasma or for pigmentation. And for rejuvenation, similar thing. So I hope that this table gives you an insight into how I approach the settings with the PicoWay, but feel free to submit a question at the end if that is unclear. And these are some clinical examples of before and treatments. And in this case, this is what I mean, that you will, in addition to the small spot size of the zoom, I would use then the resolve handpiece as field treatment. And for melasma as well, And for acne scarring, as I say, that will be then the Resolve handpiece. And for fine lines and wrinkles and rejuvenation, again, that will be the Resolve handpiece. In lighter skin type patients, you can combine the 1064 with the 532. In darker skin type patients, I tend to limit that to the 1064. This is one of my patients with acne scarring and darker skin type. So again, once again, it's acne scarring, so I'll be using the Resolve handpiece, 1064, higher fluences, more than 2 passes, and then for subsequent treatments, I can increase the fluence by an increment of 0.2 joules per centimeter squared. Now, why multiple passes? That's interesting because imaging and studies have shown that the size and the number of the LIOBs increases with each subsequent pass. So particularly when you want to have a much more of an inflammatory response, much more of a wounding effect, and much more neocollagenesis, such as the case with acne scarring, it is important to do more than 1 pass because you will have more LIOBs and larger LIOBs. In this case, this is one of my patients. So again, Resolve handpiece first, and I used lower fluence 532 as well because she has predominance of epidermal pigmentation, and then small spot zoom to treat the individual epidermal lesions. Here, one single session of melasma again. With melasma, my approach is 1064 Resolve, lower fluences, number of passes, followed by large spot zoom, 1064, low fluence, multiple passes, and mild erythema is the clinical endpoints. Now, this is not my paper, but I was very pleased to see this paper published recently, and I would encourage you to read it. And colleagues from Thailand have already published on their experience, which is comparable to ours, except they use only the Resolve handpiece with very nice results in clearance of melasma. And we're going to be publishing our series 2, so we understand more on how to use the PicoWay in melasma. This is another example of, again, the combination of the Resolve handpiece followed by the large spots zoom 1064 with low fluences. And again, in this case, however, because she was lighter skin types with predominance of epidermal melasma, I just used also the 532 Resolve in addition to the 1064 at low fluences. This is just a short video to demonstrate how this works with the 1064 Resolve handpiece. So that would be the first. And then this would be followed by the large spot zoom, 1064. So that's a large spot, low fluence, 2 to maximum 4 passes with erythema as a clinical endpoint. Some before and afters with the melasma, again, it's the same approach. And here again, you can see some nice improvements with the before and afters of the melasma. And again, that's the same approach of the Resolve handpiece 1064, followed by large spot zoom, low fluence, multiple passes, erythema as endpoints. Again, other examples and other examples. This was a case of ochronosis that you can see, which is due to exogenous use of hydroquinone. Excessive prolonged hydroquinone used with high concentration can give this particular pigmentation. You can see below the nice banana-shaped structures in the histology. And in this case, we used the combination of the 1064 followed by the 532 Resolve with these fluences. And again, with subsequent treatments, you will increase the fluence with these increments and nice results. And I'm pleased to say that we have submitted this and we have published this. This was a case that was treated with my colleagues from Mexico. I have another case that I have treated also in combination with the fractional CO2 with low density, low fluence pre-treatment with the fractional CO2, followed also by the PicoWay. This was another case of localized argyria to silver piercing of the nose, and I used the Zoom handpiece with these parameters. We had mild petechia as an endpoint, and once again, you can expect mild petechia when you're using the 1064 zoom for dermal lesions. Be careful with darker skin types, but very nice results after just a single treatment. And in this case, for example, it's predominantly epidermal pigmentation, so the wavelength will be 532. You can just use the zoom handpiece with a 3 or a 4 millimeter spot with fluences up to a joule single pass. Just look for the clinical endpoint. If you don't see that, you can incrementally increase fluence. But in this case, for this area on the mid cheek, I also did a treatment with the 532 Resolve, and that's what I mean with field treatment. So I've come to the end of my 30 minutes for the webinar, and then we'll have 15 minutes of questions and answers, and I would encourage you to submit your questions. I hope I managed to convince you that the PicoWay is a great picosecond laser that has 3 wavelengths, the 532, the 1064, and the third unique wavelength of the 785, particularly good for blue and green tattoos. It has the highest peak power of all the picosecond lasers, which means that you can have a large spot and still very short pulse duration. Once again, remember that all 3 pulse durations of the PicoWay are below 500 picoseconds, which gives you a lot of photoacoustic shattering effect with very little photothermal effects. And as I shared with you some of the clinical cases on the table, that you can also use this for pigmentation, and I'm very excited about the results we get with melanoma. And I want to thank you for your listening, and we can now open the floor for questions and answers. So you should see, you will be able to submit your questions. Okay. So there is one question about changing the depth of the LIOBs with that impact on the results of wrinkles and active scars. That's a very good question. It is not so much the depth of the LIOBs as much as it's the number and size of LIOBs. And that is why we do multiple passes with higher energies to get larger LIOBs and more numerous LIOBs, and that gives us more of a wounding effect. There is a question about the risk. How do you control the size of the LIOBs? Well, you can't, but what the imaging studies have shown is that the LIOB size with the 532 is larger compared to the 1064. And that is, of course, no surprise, because the 532 will absorb more compared to, will be more absorbed by melanin compared to 1064. So the LIOB size and number is more with the 532, and this is why you need to be more careful with the darker skin types. And also, one other finding has been shown is that the 532 associated LIOBs can also be associated sometimes with very small microvascular injury, and therefore when you use high fluences with the 532 Resolve, you can get PicoWay and that purpura, and that could also lead to potential pigmentation. So be careful with darker skin types. So for lighter skin types, when you want more impact, you can certainly use higher fluence of the 532 and can expect sometimes some purpura, but with darker skin types, I would limit that to lower fluences, and particularly for field treatment or epidermal melasma. There's another question on melasma, whether one can use higher fluences and get quicker clearance. I wouldn't recommend that. We know from experience and from all the studies with the nanosecond that using higher fluences with melasma could aggravate it and could potentially worsen melasma, so I would limit that to lower fluences rather than higher fluences. Do you use cooling during or after treatment? That's a good question. Cooling during the treatment is not necessarily required unless it's for anesthesia or distraction, but yes, particularly for melasma treatments and for a lot of pigmentation treatments, particularly in darker skin type patients, cooling afterwards helps, as that will reduce the rebound erythema and potential worsening. So when I'm treating patients who are darker skin types or patients with melasma, then I like to cool afterwards. What is the maximum number of passes? I wouldn't exceed 4 passes with the Resolve handpiece, and then again for multiple passes. With the large zoom handpiece, I wouldn't exceed more than 4 passes. With another device, there was a good study showing higher passes, more than the recommended ones, did not show any superior efficacy. So my hypothesis is that one reaches a plateau in terms of the number of LIOVs that one can generate, and therefore more subsequent passes is probably not going to lead to much more improvement, but potentially could increase the side effects. Combination treatments. Yes, combination treatments, of course. Remember, the PicoWay is not necessarily need to be used on its own. So combination treatments with melasma, for sure, you can combine that with topical treatments and or with tranexamic acid injections afterwards. In some patients, I would combine that, and there is no concern. So I would treat with the PicoWay, and then I will inject the tranexamic acid afterwards, or you can combine with topical treatment. So combination with melasma is not a problem. Combination with the fractional CO2 is interesting. I did not speak a lot about it, but I use that for some of the very resistant tattoos where I pre-treat with low density the fractional CO2 followed by the PicoWay, but these are for the resistant tattoos, and you need to have the experience in that. And also for some of the cases of nevus of Ota and of chronosis, combination treatment with the fractional CO2 is helpful too. So again, that is something that more and more of us are doing in terms of the combination treatment. There's a question about maximum 4 passes with both. Well, it depends on what you're treating. So for fine lines, wrinkles, and acne scarring, then you want to have a minimum really of around 4 passes. And if you are going to do the combination of the 1064 and the 532, I probably would then do 3 passes of the 1064 and 2 passes of 532. I think 4 passes of each could potentially be a bit too much. And if you are treating, again, for melasma or field pigmentation, you don't necessarily need to be going more than 2 passes with the resolved handpiece, because remember, you will also be doing some passes with the zoom handpiece. So it depends on what you're treating. And then I'm trying to look at other questions. How can you avoid oxidation of a tattoo? I don't think you can really avoid that. If there is obviously iron, the ferric oxides will be oxidized. So I think oxidation is inevitable. That depends on obviously on the ink. But you can do a spot test, and look for that. And even if it does oxidize and turn darker, that doesn't mean that it cannot be amenable to further treatment. You can try and treat again, and some do respond to the 1064 when they darken. And the other way is to combine with the fractional CO2, as I mentioned. Okay, someone is saying thank you very much. That's good. You are very welcome. Just looking at some. Some of the questions are repetition. Does it matter if you would use zoom first, followed by resolve? No, I don't think so. Well, there are colleagues who would use the zoom handpiece first, followed by the resolve handpiece. I like to start with the resolve handpiece and then do the zoom, and that's what we did also when we were going to publish our series, and with many of the cases that I have showed you, that's how I have done it. I don't think it's particularly a problem if you would start with the zoom first, followed by the resolve, unless you're treating epidermal pigmentation, and if you're using the zoom first for the epidermal pigmentation, then you get some darkening. This may impact on the resolve, but in general, I don't think necessarily that would matter much, but it's just the way I would do it. And can we start the treatment with melasma with Zoom? And yeah, so well, it's the same question. You can hire LIOB. And then question about LIOBs. Do we use low or high energy in scar treatment? As I said, for acne scarring, in general, higher level of energy, and in lighter skin type patients would be the combination of the 1064 followed by the 532 resolve. And in terms of the LIOBs, we are learning more and more about the LIOBs, and what we definitely do know is that the vast majority of LIOBs appear in the epidermis, and that is once again because the epidermis has most of the melanin. The melanin seems to be the main absorbing chromophore of the light that is then generating these LIOBs. Therefore, most of the LIOBs are in the epidermis. And there are some LIOBs that will be in the dermis, but the vast majority are in the epidermis. The LIOB size and number is higher in the 532 as there is more absorption compared to the 1064. But you want to have, so what we know is that the light needs to be absorbed by a target to generate LIOBs, and the target seems to be the melanin. Okay, so I think that I have answered all the questions, because some of the questions are repetition. Someone's asking whether they can pre-treat melasma first with bleaching creams and then move on to using the PicoWay. Absolutely fine, and I again answered that and mentioned it. You can do combination treatment and you can pre-treat. So the vast majority of the rest of the questions are all repetition. I would like to thank you all for taking the time to listen to me, and I sincerely hope that you found this webinar useful. Once again, for those of you who would like to hear it again, this webinar is fully recorded, and therefore you'll